Hi Nursing 602, this is Megan Sapp, and today I'm going to be talking to you about collaborative contracts. In order to adequately understand the problem relating to collaborative contracts, it's important to have some background information. Successfully managing patients with complex conditions require collaboration amongst providers. The scope of practice and the Affordable Care Act are legislation and policy affecting provider collaboration. Since the passing of the ACA in 2010, collaborative contracts in primary care practice have been an area of growing research. Since the implementation of the law, more lives are insured with not enough providers to cover them. Due to variability amongst state regulations regarding nurse practitioners' scope of practice, there are obstacles in developing national standards and consensus documents surrounding collaboration. In effectively caring for patients, nurses must work collaboratively with interdisciplinary specialists and departments. However, according to Ulrich, Woolen, Q, Chipman, Sweet, and Plemons in 2015, 40% of nurses were unable to identify good collaborative practices in nursing, and over 75% did not know of any available protocols or guidelines on the subject. Some of the issues hindering collaborative practice are poorly defined roles and responsibilities, poor communication and time management, language barriers, and difficulty with varying levels of seniority between staff members. As future advanced practice nurses, it's essential to understand how to interprofessionally collaborate to facilitate important policy initiatives with the healthcare team and provide the best quality of care for patients. What are collaborative contracts and why are they important? Morgan, Pullen, and McKinley, 2015, explained that care for those with multiple chronic conditions is fast becoming a dominant health burden for primary care. Interprofessional collaboration is essential to best care for such patients and makes the best use of finite health professional time and expertise. The authors define interprofessional collaboration as an active, ongoing partnership between individuals representing different organizations or specialties. The team works to problem solve and provide evidence-based care to improve outcomes for a mutual patient. To participate in collaborative practice, it's essential to understand how they work, as well as obstacles resulting from more patients than providers. In a review of the literature, Morgan et al. 2015 evaluated 11 studies through a systematic literature review where two main themes are apparent relating to collaboration: a top-down or a bottom-up approach. From their analysis, it was evident not one place or person will lead to successful interprofessional collaboration. The top-down approach is mainly organizational. For policies or protocols to be developed or changed, it took regularly scheduled meetings with written procedural documentation, clarification of roles and responsibilities for the team to communicate, leading them to a plan. Management structure needs to support team development through fostering their process and providing feedback on the team's performance to be useful. Communication is the key to success, with time and space viewed as both facilitators and barriers. The greater the proximity and reporting of team members, the better the outcomes for successful collaboration. These interactions could be casual and brief, but when frequent, they strengthen the team. On the other hand, the bottom-up approach addresses the characteristics of individual facilitators within the interprofessional collaboration. Themes identified in this strategy encompass shared knowledge, informal communication, and collective clinical decision-making. By sharing knowledge, teammates can learn from one another through frequent, casual conversations. These bottom-up individual factors are affected by the top-down organizational factors of the establishment structure, policy, time, and space. The goal of this approach is to promote informal communication to make the best clinical decisions and provide quality patient care. To make changes in laws and policy, I am for the bottom-up approach, with nurse practitioners driving necessary reform. For change to be effective, those recognizing the need must passionately take the initiative in finding and presenting solutions. As there are not enough providers for adequate care of insured patients, nurse practitioners must become advocates for the scope of practice change to allow for effective collaboration and access to care. Effective collaboration results in emphasis on communication, shared knowledge, shared decision making, fosters an environment of respect and equality amongst team members, provides continuity of care, enhances patient outcomes. While the Affordable Care Act was passed to provide citizens with increased access to care, it has not been successful because of the lack of available providers. Having insurance did not result in an increase in access to care. Regulations on nurse practitioners' scope of practice need to be addressed to provide patients with greater access to providers. States should take this into consideration and ease their regulations on advanced practice nurses' scope of practice to expand access to primary care. Variability among state laws regarding nurse practitioners' scope of practice has created obstacles for the development of national standards and consensus documents surrounding collaboration. Enhanced uniformity amongst the states is needed to progress collaboration efforts. Many states specify how often a collaborating physician must review nurse practitioner activities. Demonstrating compliance with such requirements can take up substantial physician time. Also, doctors who are required to sign off on nurse practitioners' decisions may be more concerned about legal exposure. In some cases, states require physicians to provide on-site supervision of nurse practitioners. These oversight requirements can disrupt the provider's schedule, particularly in rural areas. Several states require nurse practitioners to practice within a specified distance of their collaborating physician, restraining the use of nurse practitioners in areas experiencing a medical practitioner shortage. In states that require substantial physician involvement, patients may receive unnecessary and fragmented care. Other states where nurse practitioners may prescribe only limited quantities or types of medication, medical groups may struggle to ensure timely patient access to needed medications. Having to see multiple health practitioners can confuse patients, create an opportunity for error, and occupy valuable appointment slots with duplicate work. In summary, collaboration is negatively affected by difficulty partnering, differing viewpoints, lack of time, role, tension, educational elitism, more patients than available providers, and variability amongst state laws regarding nurse practitioners' scope of practice. Within my cardiology nurse specialist position, collaboration is necessary to ensure optimal outcomes, including a reduction in readmission rates. In 2009, the American College of Cardiology, the ACC, Trustee Board approved advanced practice providers with board certification. In 2010, an advanced practice provider was granted membership to the Board of Trustees as the first non-physician member. These changes were the beginning of a push for cardiac team-based care and the development of task forces, committees, and councils. In 2014, a multidisciplinary writing committee began writing the ACC's official policies regarding the contribution of advanced practice providers to the care model. They recognized the potential future physician shortage and other healthcare delivery challenges. Bush, Hamburg, Biga, Bircher, Bove, Castle, and Wyman 2015. This official team-based health policy statement addresses the training and qualification of members, their roles, and barriers to the approach. They explain that currently 19 states give advanced practice nurses statutory authority to practice without a written collaborative practice agreement with a supervising physician. Brush et al. 2015. The report highlights that the variability among state regulations regarding advanced practice nurses' prescriptive authority has created obstacles for the development of national standards and consensus documents surrounding cardiovascular team-based care. Enhanced uniformity amongst the states is needed to progress this cardiovascular team-based care structure. Brush et al. An example of effective cardiovascular team-based care is the ACC's Hospital to Home Quality Improvement Initiative. It helps with the transition of care from the hospital to home and into the outpatient follow-up environment. The aim is to reduce readmission rates for heart failure and acute coronary syndrome patients post-myocardial infarction. A key component to the process is nurses and pharmacists educating on compliance and follow-up with discharge medication management, along with how to detect signs of another event. Kaiser in Colorado implemented the Collaborative Cardiac Care Service, demonstrating the value of interprofessional teams. Cardiovascular team-based care is a paradigm for practice that can transform care, improve heart health, and help meet the demands of the future, according to Brush et al. 2015. In conclusion, communication, shared decision-making, fostering an environment of respect and equality amongst team members are the fundamental elements in collaborative practice. However, tension remains between many nurse practitioners and physicians. Physicians often doubt the clinical preparedness, especially considering the length of education of the nurse practitioner. These uncertainties lead to them believing advanced practice nurses are a burden and a risk. These feelings are even further impacted by the variable state requirements that impose complex and labor-intensive supervision requirements. These monitoring requirements then further discourage physicians from utilizing nurse practitioners. This comes from a guide to understanding state restrictions on nurse practitioner practice, 2 ways restrictive regulations can impact medical groups, nurse practitioner utilization in 2015. To overcome traditional boundaries, experiences, perceptions, and comprehension of both sides, these perspectives need to be examined. The assessment could provide valuable insight, improving the cooperative efforts and developing a model for successful collaboration, according to Schwalt, McKeans, Hiller, and Gardner 2014. Further research is needed to obtain organizational standards, practices, and policies within institutions for collaborative practice within the nursing sphere. As a future nurse practitioner, it is crucial to be an active team member with a focus on effective communication with the care team. Open communication and knowledge sharing allow for goals to be enhanced by the different perspectives, resulting in cooperative clinical decision making, which hopefully leads to better outcomes. Research evidence demonstrates interprofessional collaboration improves patient safety, patient satisfaction, quality of care, and the results of the care, job satisfaction, better staff recruitment and retention. Despite these positive results, many primary care settings have not adopted collaborative guidelines, according to Morgan et al. 2015. While there have been innovations, there is a need for further advocacy regarding policy and legislation regarding interprofessional collaboration to enhance patient outcomes. As an advanced practice nurse, my goal is to be an influential team member, providing the highest standard of care for my patients through a team approach to care coordination.